All right, guys. Good evening. I'm Dr. Sandeep, your surgery guy. Today we have a session with respect to integrated neurology. We are supposed to do our spinal cord tumors as well as the traumatic spine injuries, right? Now, the session was designed to be taken by me and Dr. Alekhya, but unfortunately, Dr. Alekhya is stuck up in a case. She has an osteosarcoma of 11-year-old boy, so they are dealing with that. So I can't do much about it. That's the part and parcel of being in this profession. uh, we will come up with that case scenario for you as well. It's a very interesting case. We spoke about it. uh, Apart from that, let's kickstart into the discussion. I will take up as much as possible from the surgery point of view, and we'll try to keep the discussion crisp so that you'll be able to understand better, right? Another important aspect is we have done the entire neurology in an integrated way. I would want you to go through the entire series. Each and every series has its own fairy tale recitation, right? So please look across it. Without wasting any further time, let's kickstart the discussion. Now, I would like to start the discussion with a very basic topic in the spinal cord injuries is your traumatic spinal cord injuries, right? So we'll be talking about the traumatic spinal cord injuries. Now, when we talk about the traumatic spinal cord injuries, now first and the foremost question is, what is the most common site, right? If they ask you which is the most common site for the traumatic spinal cord injury, the answer is going to be your cervical spine. The answer is going to be your cervical spine, right? If I say among the cervical spine, the most common site in cervical spine, it is the most common site in the cervical spine. It is going to be C5, C6, right? It is the C5, C6. Now, why cervical spine is the most common site? We all know it is the most mobile part of your entire spinal cord. So, cervical spine is prone to get injured, especially in terms of whiplash injuries, right? Now, there's a term that we call it as the scivora. Now, what is a scivora? Again, very, very important. Scivora stands for spinal cord injury. It is the spinal cord injury. W stands for without. It is without radiological abnormality. Without radiological abnormality. Without the radiological abnormality. And the point to remember, the scivora is usually seen, or it is most commonly or more commonly seen in children, again because of whiplash injuries, right? Now, these are the important aspects that you have to remember. The other ones, the traumatic spine injuries, again they are going to be site specific and the mode of injury specific, but this is the baseline data. Now, any patient of trauma, right? We have the protocol according to the ATLS guidelines. So we will use the ATLS guidelines. We'll use the NICE guidelines to differentiate. We have the Canadian guidelines also. So we'll have the guidelines based protocol, but I'll try to integrate and make it one single component for you to understand. Now, according to the ATLS protocol, any patient of trauma will be assessed as a primary survey on the basis of ABCDE protocol. We all know. Now, A stands for, we all think or know it as an airway maintenance, but it is a airway with cervical spine stabilization. It is airway. It is airway with cervical spine stabilization. B is your breathing and ventilation. B happens to be your breathing and ventilation. Just for the sake of completion, I'm just going to run through it. C is your circulation, that is the assessment of circulation with hemorrhage control. With the hemorrhage control. D stands for disability. It is the disability limitation. It is the disability limitation. E stands for expose and examine. E stands for expose and examine. This is the criteria that you need to look across here. Now, in the expose and examine, they asked you in order to examine the back, right? For the examination of back. For the examination of back, what technique are we going to use? We are going to use the log roll technique. We're going to use a technique that is called as log roll technique. Now remember, usually for log roll technique, the minimum number of people required is 3. For any associated fractures, you would require a minimum of 4 people. That is a log roll technique. In a log roll technique, a patient who's been lying down. Now if you want to examine the back of this patient, let's say this is a patient who's been lying down. You want to examine the back. I want one person to stabilize the cervical spine, one patient to stabilize the limb, the other one is to rotate the trunk. That is the minimum is 3. If there's a fractured segment, you have to stabilize the fracture segment also. Now our objective is to understand the cervical spine stabilization. Now the question is, which is the best method to stabilize the cervical spine? I would have seen in this Hollywood movies, right? Whenever there is, any site of trauma or any accidents, you see, a stretcher run to the patient, and then there's something they put around the neck, right? So the best way, the overall best way to stabilize, the cervical spine, it is by applying a hard cervical collar. Right? Now this is how you'll be able to take care of the cervical spine, because it has been proven that it is not the injury per se, but during the transportation from the trauma site to the ER, if the cervical spine stabilization is not being done, the injury gets aggravated. Now the bigger question is, how do you rule out if there's a cervical spine injury or not? Now in order to rule out the cervical spine injury, we have a criteria, right? And the criteria is what we call it as the Nexus criteria. Now Nexus is actually a X-ray based criteria that you have. So the Nexus criteria, it is to rule out the cervical spine injury, right? So the objective for Nexus criteria, it is to rule out in general spine injury. Here we're talking about the cervical spine injury. To rule out the cervical spine injury, that is the goal of your Nexus criteria. So it so happened that we went to Nexus, right? I said, Nexus, please tell me, how do I rule out the cervical spine injury? Nexus said, see dude, right? There's nothing much to worry about it. There's a very simple way you can know whether the cervical spine injury is there or not. Please, I'll let you know in a very simple form. I said, okay, fine. What is that? He says, the only thing that you need to know is there should be no posterior midline cervical tenderness. That means there should be no spinal tenderness, right? So if there is no midline cervical tenderness, if this is satisfied, then there is no cervical spine injury. As simple as that. I said, wow, great, only one criteria. This is the only criteria which is giving me 1 point. I was happy. I was about to leave. Now, just before I was about to leave, I happened to remember one case that came to my ER where a patient was, full on walker, right? From Johnny to Black, every walker he had, and that guy was completely down, right? So this is a guy who was, probably he would have had, God knows, 2-3 full bottles, and then he is just down to an ER. And in those patients, he was riding a bike, he fell down, and we are trying to see if there is a spinal injury or not. Now, if a patient is immersed in alcohol, do you really think I'll stroke his neck and he'll feel pain? Not at all, right? So see, alcohol is the medicine for all pain, right? That is the controversial statement that all alcoholics will give you, right? So if a patient comes to you in that scenario, it is very difficult for us to assess. I said, Nexus, what if my patient who has come to ER is already drunk, if he's an alcoholic, if he's intoxicated? Nexus says, good point. So let's add this. He says there should be no evidence of intoxication. Now, whenever we talk about road traffic accidents, especially if your patient is on a bike or a two-wheeler, we falls, you think about head injury. If a patient is having a head injury, the GCS will be low. If there is GCS is low, again all this tenderness cannot be appreciated in those patients. So I told the patient, the next the same thing. What if a patient has head injury and his GCS is low? How will you do this? Next is, you look smart, right? Add one more point. He says there should be a normal, there should be presence of a normal level of alertness. There should be the normal level of alertness, and there should be no focal neurological deficit. There should be no focal neurological deficit. There should be no focal neurological deficit. If all these are followed, we said there is no cervical spine injury that you can. And I was like, great. So we have, in general, if you talk, we have one criteria. There should be no posterior midline cervical tenderness, and there are adjuvant criteria. What? There should be no intoxication. There should be normal level of alertness. There should be no focal neurological deficit. And suddenly I remember one more point. What if a patient have a crush injury to the limb and is wincing in pain? I'm trying. Now imagine you're in an ER, a patient has come to you with a crush injury to the lower limb. Patient is wincing in, crying because of that pain, and you say, beta, ek second, can I touch your neck? I want to see whether there's cervical tenderness or not. In that scenario, one, the patient is not cooperative. Second, it looks absolutely stupid, and whatever is elucidating, you're not clear whether it is because of cervical tenderness or it is because of the limb disruption that has occurred. So I asked the next is the same thing. What if he has some other injury which is more painful? He says, okay, last point, we are not going to add any more further, and that point is there should be no painful, there should be no painful distracting injuries. There should be no painful distracting injuries, and that's it. Now this is the entire criteria that you need to know. So to be very honest, the original criteria is only one, right? Nexus told, just remember this. We confused him. He asked him more questions. He says, okay, go take these 4 adjuvant criteria to rule out cervical spine tenderness or the cervical spine injury, right? Now, according to the Nexus criteria, once you have dealt with this, and if any one of them is positive, you need to evaluate, right? In terms of investigation for any of the spinal injuries, you have to do both CT as well as MRI, right? Now, the reason I am telling CT, the CT is to look for any bony injury. If there is any bony injury, and MRI is to rule out the spinal cord injury. It is to rule out the spinal cord injury, right? So these two has to be combined together in order to get the best diagnostic criteria. Most of the traumatic fractures will be dealt by your orthopedician. Alekhya ma'am will take another series for that. For now, remember, majority of the cervical spine can be managed conservatively. Can be managed conservatively until unless there is no severe disruption. Until as there is no severe disruption or severe focal neurological deficit. If those are present, then we'll go with surgical implication. Otherwise, conservative management will be more than enough. One important concept that you can get in a traumatic spinal injury is your spinal shock, right? I know it's a topic that has to be dealt in a different context. So we'll simply go with spinal, or also called as your neurogenic shock. Now, what are the parameters that are going to vary in this particular status of shock, right? So we'll try to elaborate and see what will you see in a spinal or a neurogenic shock. Now, the components that I would like to review for you is going to be cardiac output. We'll look at the systolic blood pressure. We'll look at the heart rate, right? We'll look at the jugular venous pressure, the pulmonary capillary wedge pressure, the peripheral vascular resistance, and the skin temperature, right? So these are the parameters that I would like to evaluate in terms of neurogenic shock for you to go through it, right? Now, in order to understand any shock, I always tell there's a simple arcade that you need to follow, right? Now, this is what we will represent as heart. Heart has 4 chambers, we all know. This is the right atria, this is the left atria. This is the right ventricle, this happens to be the left ventricle. Remember, the right atrial pressure is measured by JVP. So JVP basically tells you what is the status of pressure in the right atria, and the left atrial pressure is measured by pulmonary capillary wedge pressure. It is the pulmonary capillary wedge pressure, right? Now, whatever amount of blood that is present in the left ventricle just before the contraction is what we call it as preload. From here, the blood will be poured into the aorta, right? Now, as the blood is going to eject from the left ventricle into the aorta, every time the blood is pumped into the aorta with each contraction, that is what we call it as stroke volume, and per minute is what we call it as cardiac output. So every time the left ventricle contracts, the amount of blood that is going to come out, the amount of blood that is going to come out from the left ventricle into the aorta, that is what we call it as the stroke volume. And if you do it for per minute, that will become the cardiac output. Now, right at the arch of aorta, you have a specialized pressure receptor, and this pressure receptor is what we call it as the baroreceptor. Now, the function of the baroreceptor, there are two sites where you have baroreceptors. One is the arch of aorta, another one is the carotid bifurcation. Now, these baroreceptors, as the word itself suggests, they are sensitive to any pressure change, right? Now, whenever there is drop in aortic pressure, the baroreceptors are going to get activated. Whenever the baroreceptors are going to get activated, they will activate the sympathetic system. Whenever the sympathetic system is going to get activated, they will cause excessive release of your catecholamine, that is your epinephrine and norepinephrine. The effect of epinephrine, norepinephrine on the heart is that they are going to increase the heart rate. So whenever there's decrease in pressure, the heart rate is going to be increased because of this simple phenomenon. Now, as the aorta is going to travel and then it is going to bifurcate the blood to various organs in the body, based upon the requirement, it is going to split into two common entities. One where you have, or where the blood requirement is more, that is what we call it as the vital organs, and one where the blood requirement is less, and this is what we call it as the non-vital organs. Now, invariably, we know that the blood that is going to come here will go more to the vital organs, and the less amount of blood will go to the non-vital organs. Less amount of blood will go into the non-vital organs. Now, once the blood has done its job, it is going to recollect back from the vital as well as the non-vital organs, and then it will be recirculated back into the heart. It will be recirculated back into the heart, and this circuit will complete on the right atria. From there, it will go into the right ventricle, into the pulmonary artery, from there into the lungs, then it is going to come back via the pulmonary vein into the left atria, and the cycle continues, right? Now, the blood that is going to be pumped out from the vital and the non-vital organs and gets collected here, this is what we call it as vascular pool. From the vascular pool, the blood is going to go back into the right side of the heart, and then it continues to pump, and the circuit is complete. Now, as we spoke, the amount of blood that is going into vital organs will be more when compared to non-vital organs. And who determines it? This is determined by a component that is called as peripheral vascular resistance. It is the resistance offered by the peripheral blood vessels to the blood flow, so that more amount of blood can be directed to vitals, right? So it's a simple way. I can give a small analogy to understand, right? Let's say you and your brother are there. Your father has decided to give 100 rupees each as pocket money. You know? Now, the minute the father offers, because you're greedy, you take your 100 rupees, but your brother thinks, he says, Papa, you give me only 20 rupees, you give rest 80 rupees to Bhaiya, right? Your father says, why? He says, no, I can sustain with 20. My expenses are not that, exuberant, but this guy cannot live without that 80 rupees. He has to get 180 rupees. Your father looks suspicious. He says, why? Papa, you will not understand. He has a girlfriend he has to maintain. There's a lot of expenses that he has to deal with. Please give it to him. Your father tries to enforce it, but your brother says more and more and more pushily, and your brother is very angry about it, right? So he's resisting your father. Now, because that resistance, your father didn't want to give you that extra 80 rupees. It is the resistance shown by your brother that you're getting that extra 80 rupees. And that resistance is not from you, from your brother. So it is external. So it is peripheral vascular resistance. It is resistance offered by the non-vital organs or the vessels in the non-vital organs. So the more amount of blood can get into vital organs, right? As long as PVR is there, vital organs will get adequate amount of perfusion, right? Now, in a simple context, I can simply say this: you take heart as, or we can say the vascular pool as compartment A, the heart as compartment B, and the peripheral vascular resistance as compartment C. Whenever there's damage in compartment A, we call it as hypovolemic shock. Compartment B is what we call as cardiogenic shock, and compartment C is what we call it as the distributive shock, which can be a neurogenic shock, it can be a spinal shock, it can be an anaphylactic shock, it can be a septic shock. So in general, when we talk about in a neurogenic or a spinal shock also, it is a loss of peripheral vascular resistance, right? So whenever the peripheral vascular resistance is going to decrease, that means the resistance offered by your brother is less. So your father can now give him more money, or else in simple words, now your brother also have a girlfriend. So he also wants his equal share of money. So as he's going to get his equal share of money, what is going to happen now? Blood is going to get equally distributed. Initially more to vital, less to non-vital. Ab dono mein equal. So because of that, the demand in the vital is more, but the supply is less. Demand in non-vital is less, but the supply is more. So right, so vitals mein demand zyada hai, supply kam hai, right? Now because of this mismatch, the vital organs are becoming hypoperfused, hence the status of shock. Non-vitals are getting more than adequate blood. Skin is considered to be a non-vital organ, so blood flow to the skin will increase, hence the skin temperature. Blood is responsible for calorigenesis, and that calorigenesis will cause increase in skin temperature, right? Now, all that you have to understand, the blood is not gone anywhere. It is present in both your vital and non-vital organs. The only problem is it is more in non-vitals than required, hence there is systemic state of hypoperfusion. Now another beauty word that you remember is whenever we say this loss of peripheral vascular resistance, that means there is universal vasodilation. Even your aorta, all the blood vessels are exuberantly dilated, they are not able to regulate the pressure, right? So what is going to happen is, as the blood which is coming from the vitals and non-vital organs will eventually come back to the vascular pool, so the volume of blood in vascular pool will remain same. That means the amount of blood going into the right atria will also remain the same, right? So initially, because the amount of blood going into right atria is normal, so the right atrial pressure will also remain normal. So initially JVP will remain normal. If the blood here is normal, that means right ventricle is normal, that is left atria is normal, left ventricle is also normal. So I can say pulmonary capillary wedge pressure initially will also remain unchanged, right? Now what is going to happen when we say the blood in the left ventricle is same as before? So I know the cardiac output is calculated as preload minus afterload, right? So when I say preload minus afterload, that is amount of blood available in left ventricle before contraction, and what is afterload? Amount of blood that is left in left ventricle after contraction, right? So the basic concept of preload and afterload is, in preload, if you take this as a representation of left ventricle, in preload, it is the amount of blood that is available in left ventricle before contraction. Afterload is the amount of blood that is left in the left ventricle after contraction. That will give you cardiac output, right? Now, the component that you have to understand is cardiac output is calculated per minute, right? Another way you can calculate cardiac output is equal to stroke volume into heart rate. It is the stroke volume into heart rate, right? Now what is the stroke volume? It is the amount of blood that is pumped with every contraction. Now because the preload is normal, with every contraction the blood going out will normal, so the stroke volume remains normal, right? What will happen to heart rate is a bigger question. Now what is going to happen is, because there is a universal vasodilation, I can see the aorta is also getting dilated. Now because the aorta is getting dilated, what will happen to the net pressure in the aorta, right? The amount of blood coming from the left ventricle to aorta was same as before, but the size of the vessel is now larger. Now what will happen to net pressure? The vessel is becoming bigger, the volume of the blood in the vessel remains the same, so net pressure will decrease. That means what? The systolic blood pressure will decrease. Now the systolic blood pressure will decrease, our baroreceptors are going to get activated, same epinephrine or epinephrine, so will be compensating increase in heart rate. What will happen to cardiac output? Now cardiac output is stroke volume into heart rate. Now heart rate is increasing by this equation, because stroke volume remains normal, heart rate increases, the cardiac output initially will increase, right? So these are the parameters that you will see with respect to spinal or neurogenic shock. Yeah. So we need to be absolutely sure on these parameters to understand our management protocols. In the lecture of shock, which we have taken in our MedEd app, you can see each and every protocol that has been laid down across here. But this is the integrated form of you to understand the spinal injuries can present to you with spinal shock as well. Okay. Now, coming back to few other components of the spines, we'll talk about in terms of the components in an integrated fashion. So I'll be talking about the pediatric part of the neural tube defects as well. Now, when we talk about the neural tube defects, right? It is also called as the spinal dysraphism, right? It is also called a spinal dysraphism. I can divide them into two different components. One, we have the spina bifida aperta. Aperta means open defect, and spina bifida occulta, which is hidden defect, that is not visible. Now, clinically, it is occulta, which is more commonly seen when compared to aperta, but aperta is more dangerous, right? So, aperta means open defect, spina bifida occulta means closed defect, it is not visible. Now, these open defects, we can component or we can categorize them into two basic forms. One is your myelomeningocele, another one is your meningocele, right? Out of myelomeningocele and meningocele, remember it is a myelomeningocele which is more commonly presented when compared to meningocele. Now, in the closed defect, that is your spina bifida occulta, right? Here you will see the following components. Number one, you can have the simple spina bifida occulta. You can have the spinal dermal sinus. You have the lipomyelomeningocele. You have the diastematomyelia, right? Tethered spinal cord syndrome, right? So these are the closer defects that you're going to see. Surgically, I am more aligned with your myelomeningocele, which you will be seeing very commonly in terms of your clinical practice, right? Now, imagine this is a representation of your ectoderm, right? Now, ectoderm is going to give rise to a small invagination, and this invagination in future, it is going to develop into the neural tube. It is going to develop into the neural tube. This is an ectodermal in origin, and this neural tube in future will give rise to the spinal cord, the brains, as well as the meningeal layers, right? Now, this is how a normal spinal cord would look like, but because of an incomplete development, if there is an incomplete development or the incomplete closure of the spinal cord, that can result into your spina bifida, right? Or in terms of, it can result in a condition that is commonly referred to as the spinal dysraphism, right? Now, what do you mean by this, right? Now, when you talk about there's an incomplete development, that usually occurs in 21 to 28 days of gestation, even where the patient does not realize the patient is even pregnant also, right? Now, this is usually because of your folic acid deficiency, that is your B9 deficiency is integrated. Now, once there is a B9 deficiency or incomplete neural cord is formed, or the incomplete development of this neural cord occurs or neural tube affects, this will result in incompletely formed the vertebral column also. So you will notice that this area, of the vertebral cord will be ill formed, or it fails to fuse, or it fails to form. So in simple words, I can say it fails to fuse. Because it fails to fuse, what is going to happen? The meningeal layer that is present inside this can invaginate out. Now, it depends whether the spinal nerves or the spinal cord, will it invaginate out along with the meningeal layer, or it is only the meningeal layer that invaginates, leaving behind the spinal cord in its position. Now, if both spinal cord and the meningeal layer are going to invaginate out, this is what we call it as the myelomeningocele. It is the myelomeningocele. It is a myelomeningocele. If only the meningeal layer is going to invaginate, leaving the spinal cord in its position, this is referred to as the meningocele, right? Now, this is the same objective that I've shown you. This is the myelomeningocele, and here you can see only meningocele, only the meningeal layer. You can see the spinal cord. So just for the sake of understanding, this is your meningeal layers. This happens to be your meningeal layers. This happens to be your spinal cord. This is the spinal cord, and this is the skin covering. Now, you can have an open myelomeningocele or a closed myelomeningocele. Open means there is no skin covering. Closed means there is presence of skin covering. Again, they're very dangerous because if you don't treat them as early as possible, it can result in meningitis or ventriculitis, right? So you need to be absolutely spot on. So the same thing I've given you. Again, clinically, it is very difficult to identify whether it is meningocele or myelomeningocele alone until you open the sac and see for yourself, right? I've given you the same clinical representation on the either end. This is only your meningocele. This is your myelomeningocele. This is your meningocele. This is your myelomeningocele. Right? Now, important points about the myelomeningocele that has to be engraved into your brain. Number one, the most common type of spina bifida aperta. Right, myelomeningocele is the most common type of spina bifida aperta, but the most common type of spinal dysraphism is your spina bifida occulta. Right, occulta is hidden. Right, now it is associated with benign deficiency during pregnancy. We have spoken. It is associated with varying degrees of both motor and sensory deficit. It can involve both bladder as well as bowel dysfunction. Now the deficit depends. Now this is your exam question. The degree of deficit is directly proportional. It is directly proportional to the level of defect. More higher the defect, more severe the presentation. More lower the defect, less severe is the presentation. 80% of the patients are associated with hydrocephalus. In fact, 60 to 65% of the patients, even after surgical correction, will require a ventriculoperitoneal shunting of the CSF fluid. They're also associated with Arnold-Chiari 2 type of malformations, where you will see the lower brain is going to sink down via the foramen magnum and going to sink downwards, right? So around 90 to 95% of the patients are associated with Arnold-Chiari 2 malformations. Now, how would you like to manage them? The surgical closure. This is your exam question. By when? It should be closed within 24 to 48 hours of birth to avoid, as I told you before, meningitis as well as ventriculitis. To avoid meningitis as well as ventriculitis. Can you diagnose this condition prenatally? Absolutely, by looking at the serum and amniotic, the AFP levels as well as prenatal ultrasound, right? Now, they are not specific, but prenatal ultrasound can give you a structural deformity that you can see, right? So this is important with respect to your myelomeningocele. Now, when it comes down to the spinal cord tumors, again, the spinal cord tumors can be divided into 3 different varieties based upon their location, right? Now, what are the 3 different types? You have the extradural, you have the intradural, and the intramedullary. Now, when I say it is extradural, that means the lesion is going to be present outside the dura, that is outside the meningeal layer. So this is your extradural. Intradural is going to be inside the meningeal layer, compressing the spinal cord. Intramedullary, it is arising from the spinal cord, right? So it's simple. When I say extradural, it is from outside. It is outside the meningeal layers, compressing the spinal cord. Intradural, it is arising within the dura, compressing the spinal cord, not arising from spinal cord. Intramedullary, it is arising from the spinal cord alone, right? So what is the, out of these 3, which is the most common variety? That is your exam question. Extradural type of spinal cord tumors are the overall most common type. Now, what is the most common cause for this? It is usually secondaries or metastatic disease. The most common cancer causing secondaries in spine. For females, it is going to be breast. For males, it is going to be prostate. It is going to be prostate cancer. Okay? Now, when it comes down to intradural, 3 examples. There are 3 common ones: schwannomas, neurofibromas, and meningiomas. Intramedullary is going to be ependydymoma. It is going to be the ependydymoma, astrocytoma, as well as hemangioblastomas, right? So these classification itself is the exam question, that which of the following is extradural, intradural, or intramedullary. How will they present to you? The clinical presentation is quite same for any spinal cord compression or spinal cord injuries. There'll be presence of pain, weakness. Now, weakness will depend upon the level and the site. Is it on the same side, on the ipsilateral side? Is it having a crossover presentation? That all depends upon the level of the tumor that is arising. It can result in the conus medullaris syndrome, the quada equina, and the Brown-Séquard syndrome, which is explained detailedly in your previous neurological sessions, right? Now, you have the sensory disturbances. There will be gait changes, the bowel and bladder dysfunction, and sexual dysfunction as well. I would like to evaluate for bony lesions, it is CT. For MRI, for spinal cord, it has to be your MRI, right? So usually we combine these two to get an integrated diagnosis. Remember, the surgery should be done for all symptomatic cases. What is the approach? How would you like to treat, or what is your approach for this case? That has to be your dorsal approach, right? The dorsal approach. And remember, initial treatment. Now, this is an important point. The initial treatment for extradural spinal cord compression due to secondaries is radiotherapy with 3000 centigrade units over a period of 2 weeks, which is spread on equivalent basis, right? So these are with respect to your spinal cord tumors as well, right? Now, spine per se from an undergraduate level is not that extensively asked in your exam, but this is in general from trauma, from congenital deformities, and in terms of tumors are the maximum questions that they can ask you, right? Now, if there is a disruptive injury to the spine, they can put a pedicle screw fixation. That is one that will be dealt in your orthopedics. But apart from that, nothing significant is going to be asked, right? We've already dealt with all the aspects of the discussion in terms of the previous localization of lesions. We have spoken about it. We've spoken about how do you address it, what are the findings which you see on radiologically. All that has been discussed previously as well, right? So this is in a nutshell that you should be aware of in terms of the spinal cord injuries, the spinal cord tumors, right? That is from my end, guys. Thank you for attending an integrated session. It's been lovely as always. Any questions, fire it away. Stay in touch. We have a Telegram group, we have an Instagram group. You can always write down there, send your questions. We'll discuss cases as well, and we'll try to help you in your journey as well, right? So it's been an amazing session, guys. Thank you so much, right? Looking forward to many more sessions. Please do MCQs, solve questions, solve clinical questions, take clinical scenarios. That will tell you that how much you have retained and how much you have not retained, right? With that, signing off, Dr. Sandeep, your surgery guy. Thank you, guys.